on accelerating AMR action through antimicrobial stewardship in the Southeast Asia region. My name is Sabiha Isaac. I am chairperson of the Global Respiratory Infection Partnership, sponsored by an unrestricted educational grant from Reckitt in the United Kingdom. Reckitt has sponsored this pharmacy-led stewardship initiative in partnership with the International Pharmacy Federation since 2019. It is my pleasure to introduce the AMR advocates for the region who will be facilitating the workshop. Manjari Garat is Vice President of the International Pharmacy Federation and Principal of K.M. Kundani Pharmacy Polytechnic in India. She is also the Vice President of the Indian Pharmaceutical Association and Chairperson of the Community Pharmacy Division of the IPA. FIP recognized Manjari with the Fellow Award in 2016 for her services to community pharmacy and the pharmacy profession. Ms. Garat was also the recipient of the Ishidate Award of the Federation of Asian Pharmaceutical Associations in 2018, the first Indian woman in pharmacy to receive both awards. Veera Tongrod is a pharmacist and lecturer at the Faculty of Pharmaceutical Sciences in Huachior Chalempreket University. He has been the Vice President of the Thai Community Pharmacy Association and the Thai Drugstore Club from inception and has held several leadership roles in both organizations. Dr. Tongrod is the Vice President of the Pharmaceutical Association of Thailand under royal patronage. Over to you, Virat and Manjari. Thank you.
Thank you, Sabiha, for your introductions. And welcome all participants to this AMR event from Southeast Asia region. Next slide, please. Today, our agenda will start with the AMR roadmap that we established last year and its progress in this year. And then we will have 3 case studies from 3 panelists that represent the good model on AMR in Southeast Asia. After that, we will have like a panel discussion and Q&A. You can write your question in the Q&A box. And after that, we will like a voting for choose to select our representative from our region to present in the global in the next week. Next slide, please. Today, our objective is have 3 objectives. The first one is to highlight the leadership role of the pharmacist in antimicrobial stewardship. The second is to drive behavioral change and commitment to AMR initiative through a 3-year AMR roadmap. And the third is to share learnings and best practice from across the region to inform future initiatives in prevention of AMR. Next slide, please. Last year we have like a Congress 220, and we have set our roadmap in the area. From the picture, you can see we have 3 key action areas. The first one is education or build capacity. The second one is policy or to be our opportunity. The third is a public health and it's like a motivation. From the key actions area, we follow with the strategic objective of the global action plan on AMR of the WHO. In the first is the increase awareness and transform. Increase awareness and transform, increase awareness and understand of AMR through effective communications, education, and training. The second is the reduce the incidence of infection through effective sanitation, hygiene, and infection prevention measures. The third is optimize the use of antimicrobial medicine. From this strategic objective for the first, I have to suggested initiative as shown in A and B. A is to training of pharmacists and pharmacist staff and the whole supply chain through continuing professional development programs. For B, public awareness campaign by civil society and government body that educate and appropriated treatment option. For the second, reduce the incidence of infection through effective sanitation, hygiene, and effective prevention measures. We have two suggested initiatives, C and D. C, hospital to follow strict practice for infection control measures and strict monitoring by authorities. For D, to develop integrated AMR management in hospital, or we call it in short IAM. For the third strategic objective, optimize the use of microbial medicines. We choose to suggest this initiative as shown in E and F. E is to reclassify oral antibiotic to be dispensed by community pharmacists only and stop OTC antibiotics. And F, regulators to enforce existing drug laws strictly and reduce number of additional fixed dose combination in the region or in the country. On all these 6 initiatives, we will show in detail in next slide. Next slide, please. Next slide, please. Okay, thank you. From our roadmap initiative, develop previous slide, please. Back to the, yes, thank you. For A is a training of the pharmacist staff and the whole supply chain through CPD. We, in this year, we have achievement by special project launched on AMS, several training programs for community pharmacists and hospital pharmacists throughout the year. And the next year, we plan that to encourage to scale up the forward, to scale up the effort in educating and motivating pharmacists through state and national pharmacy council and association. For the roadmap initiative number B, public awareness campaign by civil society and government bodies that educate and on appropriated treatment options. This year, we create awareness campaign for consumer through webinars, on-site and online events, and newspaper articles. Next year, we try to continue to create and educate public awareness on AMR and appropriated use of antibiotics. For the roadmap initiative C, hospital to follow strictly practice for infection control measures and strict monitoring by authorities. This year, we set like a KPI for the government hospitals. We implement and monitor to control the use of antibiotic as needed, and the result is good, achieve the target. And next year, we will expand ours to other stakeholders, such as the private hospital, to join this practice. Next slide, please. Next slide, please. Yes, thank you. The roadmap number D, doc, develop integrated AMR management or IAM in hospital. This year, Thailand healthcare professional work like a team, IAM team that include physicians, pharmacists, nurse, medical technologists, and etc. They work together to combat AMR in government hospital in Thailand. And next year, we plan to persuade or invite other stakeholders to join this practice. For the roadmap number E, reclassify oral antibiotics dispensed by community pharmacists only. Stop OTC antibiotics. This year, Thai FDA enact to stop OTC antibiotics, and this antibiotic must to dispensed by community pharmacists, and also we reclassify essential antibiotics such as anti-tuberculosis drug or anti-TB drug to prescribe in the hospital by the physician only. In the next year, we will surveillance the use of other essential antibiotics to use it appropriately and effectively. For the roadmap initiative number F, regulators to enforce existing drug laws strictly and reduce number of the rational number of fixed dose combination in region and country. In Thai authorities enforce to stop use of antibiotic in animal feeding or food of the animal for promote growth under veterinarian consideration and let under consideration of the veterinarian and replaced by local herb product. Next year, we will enforce it the same measure to use antibiotics strictly in the past. Next slide, please. The next will be the panel discussion. Today we have three panelists. Let Manjiri, please go on this section.
Thank you so much. Thank you, Dr. Virat, for taking us through the AMR event objective for today, as well as informing us the progress of the roadmap. And congratulations for all the efforts gone into making the progress. And I can see we are trying to make the progress in every sector, the education, the continuing professional development programs, as well as consumer sensitization and advocacy with the policymakers. So congratulations to all of us, but lots remain to be undone in this area. And we are going to have a very lively panel discussion on the same. I also thank Sabiha for introducing us and for chairing all these GRIP and FIP AMR Commission events. So we have three panelists today who are going to talk about their own efforts in the area of antimicrobial stewardship. The first one is Dr. Karthik Rakam, who is Doctor of Pharmacy, PharmD from India, and he's the first he's from the first batch of PharmD from India. A PharmD program started in India in after 2000, and he's from the first batch, and his professional objective is to transform the pharmacy practice. He wants to bring the change in the pharmacy practice, the way it is practiced right now in India. So I call upon Dr. Karthik Rakam and to give your, to inform us your initiatives. So it's all yours. Over to Karthik. Next slide, please. And I invite Dr. Karthik, and thank you, Karthik, for joining.
Thank you, ma'am, for introducing me, and thanks Reckitt and FIP for this opportunity. So is my voice clear?
Yes, we can hear you well. Go ahead.
Okay, so my initiative is about sharing my knowledge with few students I know and see how it has resulted in improving the way antibiotics are used. So before I directly go into my initiative, I would like to talk my observations and experience based on which I thought of taking up the student education initiative. So while I was doing my PharmD, I was fortunate to learn many aspects related to use of antibiotics, and I could identify certain areas where there is a scope for improvement and where a pharmacist can play a key role. So on top of that list is antimicrobial prophylaxis in surgery. I did a small study where I observed what antibiotics are given, how many doses, for how long, and I found doctors belonging to same department, let's say orthopedic department, performing same kind of surgery, total knee replacement surgery, but giving different regimens for antimicrobial prophylaxis. So then I also happened to notice there is a gap or a scope for improvement in how antibiotics are administered, because this also results in change of outcome. So most of the times the instructions are not written very clearly. It is simply written amphotericin B 1 vial IV once daily. So what does that 1 vial mean? It can be 50 mg, 100 mg, it can be any strength. And the instruction says IV, but it is not clearly written in the sense if it is IV infusion, what fluid should be used to dilute that antibiotic, how much of that fluid should be used, what should be the rate of infusion, what happens if that infusion rate is not maintained properly, because I have seen patients developing infusion related ADRs purely because of faster infusion, and that happened because there were no set protocols, or even when protocols are there in place, they were not followed. And the other simple thing I noticed is, and I practiced, is whenever doctor prescribes an antibiotic, I note down the start date and keep a count of number of days the antibiotic is used. And after the end of prescribed duration, I take it to doctor's notice and get it stopped. Sometimes because of their busy schedule, they ignore, they forgot to do. And other area where a lot of involvement of clinical pharmacist is there is the dosing of antibiotics, especially optimizing the dose, individualizing the dose with respect to patient's body weight. When I say body weight, it can be actual body weight, it can be ideal body weight, it can be lean body weight or adjusted body weight or dosing weight. Most of the times all these factors are not considered and antibiotic is simply given based on actual body weight. And even that actual body weight is not the most recent one. Let's say patient get admitted today, but doctor starts antibiotic on day 10. Sometimes they don't check the weight on day 10. They still consider the weight checked on day 1 to dose, which might result in few errors. And a lot of times doses are not adjusted based on renal function. And when it comes to food, some antibiotics are administered, has to be given before food, so they are absorbed properly and we get best outcomes. And some medications are available in different strengths. So if an effort is not taken to educate the patient well, they might get an overdose. And when patient get discharged, the medication has to be audited. I have seen cases where instead of giving 1.2 grams once weekly, patient ended up getting 1.2 grams once daily. So in that way, there were some cases of ADRs, drug interactions, and especially with TB and HIV medications, where the factor of drug interaction was not taken into consideration, resulting in treatment failure or development of an ADR. Next slide, please. So what I've done is, based on all the knowledge I gained by reading standard textbook resources and talking to doctors, I thought of sharing this knowledge with students and see if we can implement that knowledge and improve the way antibiotics are used. So I started by doing workshops where I take a case study, tell them clearly how errors happen in spite of the existing healthcare team having a doctor, the existing pharmacist, nurse, patient, and other providers. So the aim was to generate interest and tell them how errors can still happen, and then follow up the initial workshop with a series of sessions where they get to know more, and later involve them by giving small activity and task. In fact, we had a task for this antibiotic week where they talked to their own family members in the house, identified if they are using any antibiotic, and educated them about the importance of using it as prescribed. So overall, I could see this initiative has resulted in increasing the awareness about the critical role of pharmacists in promoting antimicrobial stewardship, resulting in optimizing the use of antimicrobials. So what I have learned from this experience is it can definitely be replicated in any part of world, especially in countries where pharmacy is getting transition from dispensing to clinical pharmacy and also pharmaceutical care. And so what I learned was to take that initiative. I did not see a doctor expecting a pharmacist or calling him and asking him to check about antibiotics. It has to be our initiative. We should be proactive, reach out to them and clearly tell them our competency. And I'm sure they will agree and involve us as a part of their team. And while talking to students, I tried to highlight the problem by taking case studies as example, so that they realize the importance of reading from standard resources, not limiting to textbooks where concise information is there. And they could clearly see an impact a pharmacist can create. And the challenges I saw was there is lack of motivation. And that motivation, I say, our half-life is too short. So they are motivated only for short time, but they again go back to there are no scope opportunities for pharmacists to do something. So what I noticed was lack of consistency. They are motivated, but not consistently maintaining that motivation, and not enough support also, especially from education institutes and other authorities to take this knowledge to more and more students. So I end my presentation here. Thank you. Sorry if I have taken more time. So over to Manjari ma'am.
Yeah. Yes. Thank you very much. That was really an excellent presentation, and your understanding and your experience of clinical pharmacy is wonderful. And you're trying to educate the fresh PharmD students and preparing them for their future role. So highly appreciated. Now we go to the next presenter, and we have next presenter, Mr. Tilak Gajendran. Can we have the next slide, please? Welcome, Tilak. Tilak is a community pharmacist. He has his own Medox pharmacy in Hyderabad, India, and he's got more than 10 years of experience as hospital pharmacist, clinical pharmacist, and community pharmacist in Australia. And now he's in India with his own Medox pharmacy. So we are eager to hear from you, Tilak, and it's all yours. Thank you for joining.
Can I?
You can go ahead. Yes, it's all yours. Please.
Sure. Can you see my video? Is audible? Am I audible?
You're fine.
Just a second.
Yeah, now we can see you. We can see your slide and we can hear you well. So all set, go ahead. Yeah.
Thank you very much for the opportunity to Manjari ma'am, GRIP and the FIP. It is a pleasure to present today in this environment. So yeah, it's my initiative is to reduce the antibiotic resistance in the society here where I have started. It's just been 1.5 years. So to start with, we have with respect to the core elements of antibiotic stewardship, we have the commitment for that, and we have an action or for the policy or practice. And as of now, there is a third component, which is tracking. Right now, we have not implemented that, but we do have the fourth component, which is education and experience to the pharmacists or expertise, which we are trying to implement in our practice daily. So let's look at what we do at Medox in terms of engaging the audience. So when the customer comes, they basically ask, can I get an antibiotic for cold, or I've got a cough. So we ask relevant questions. Is that really, do you have fever or more any phlegm or sputum coming out, or you have back pain and you have pain in the sinuses. And when they say, no, we don't have it, and we ask them, who recommended the antibiotics to you? Then they say, oh, no, my friend recommended it, or my father recommended it, so whoever it is. So we just inform them that antibiotics are not not to be used for common colds and coughs and in that way, unless it's a very bad infection and you need to really see your doctor who needs to prescribe it. So that's how we engage the audience. So in terms of engaging the key steps involved in that, we understand the customer request, even the doctor's prescription. So as I said, with customer already explained about that, but if it's like more about the doctors, we see if the doctor has written the correct antibiotic for the correct condition. So if the patient comes up with skin and soft tissue infection, if the doctor has written say amoxicillin clavulanic acid, we recommend them to go for the staph-specific antibiotic like dicloxacillin or cloxacillin with a combination of ampicillin. Or else, if it's really bad, when we recommend some azithromycin. And that helps the doctor to understand, like, oh yes, this is the rationale behind what antibiotic I need to use for this specific condition. And that really helps the doctors, especially young doctors, or even if there are registered medical practitioners who are not like as qualified as an infectious disease consultant, to understand it and prescribe the correct medication. So we counsel the customer like what are the common side effects you can get from antibiotics, why it should not be used for this common cold. So especially with children, like it can cause like autoimmune disorders if it's used in the long run without consulting the doctors or pharmacists, and super infections like Clostridium difficile. And also, like we talk about the common side effects like diarrhea and abdominal disturbances and etc. So the third point, what I've written here is avoid dispensing. Is basically if the customer is very persistent that I need antibiotics without a doctor prescription, or I need this specific antibiotic which is not even rationale behind for that condition, we say we cannot dispense it until your doctor clearly writes the medication and with directions and the quantity and start and stop date. So that's what we do at Maddox Pharmacy. So what we found is that these gave an outcome of, so basically now our customers, the regular customers, they basically understand the rationale behind using the antibiotics, that they should not use it unless there's a good amount of infection, not for just a common cold and cough and even basic bronchitis. So we ask them, we give them like other counseling to have more steam inhalations and that sort of thing. So they respect the pharmacists for giving them the insight, and the doctors, even if they are not really sure about certain rationale behind certain antibiotics being used for certain conditions, when we talk to them, they do really appreciate us for giving that insight to them. So in terms of overall impact, so we have in our area of practice, we have reduced the irrational use of unnecessary use of antibiotics, and the counseling to customers as well as physicians on the rational use has increased the prescribing of the correct choice of drug. So what I can see from the key learnings what we are doing in our practice is that, yes, it can be done throughout India. And we would appreciate the Indian government and law enforcement authority to regulate the pharmacy practice and have more pharmacists on board, and auditing that should be done by the drug control department in terms of antibiotic usages. And so yeah, so this is really helpful. And even like pollution control board can like what's happening in Thailand is that they are not using antibiotics for plants. And so here, even now, like with the animal like industry, meat industry, I would request our government to take action on not using too many antibiotics as well as steroids, in animals, and even with pollution control board not to let any antibiotics mix up in the water bodies, which can cause resistance in the society. So that's our stand on as a retail pharmacist to reduce antibiotic resistance in the society. Apart from that, if we are like hiring new pharmacists, in the job description, we do tell them about that this is your role to talk about antibiotic resistance to the customers as well as to the physicians. And so use evidence-based treatment recommendations if you're talking to a physician. And if it's like a normal cold and cough and, as slight bronchitis, we also recommend our pharmacists to use delayed prescribing method, or watchful waiting. So ask them to do steaming and avoid antibiotics unless it's necessary. Yeah, and also with education, as I said, we are educating customers on all the aspects of what antibiotics can cause to damage to the, and if it's used in the long term, like Clostridium difficile, and also if there's a disturbance with the microbial flora in the intestine, how it can cause some autoimmune conditions as well. So yeah, this is the way we do with Medox Pharmacy, and thank you very much. I don't want to take too much time because there's a lot to talk about it, but thanks for the time given to me, and appreciate that.
Thank you, Tilak. Thank you, Tilak, for telling us about your initiative and your efforts. I know what kind of struggle one must be having when trying to do the rational dispensing of the antibiotics in our part of the region. So we'll come back to you with more questions, and then that time you can tell more of your experiences or your thoughts. I encourage all the attendees here, please kindly put your questions in the Q&A box, and we will be picking up the questions at the end of after the third panelist speaks about his experiences. So please requesting you to put your questions in Q&A box. Now we move on to the third panelist, Mr. Kelum. Hello, can you put the next slide, please? Yes, Mr. Kelum Jayasurya, and he is from Sri Lanka, and he is the manager of pharmacy operations of one of the biggest private hospital chain in Sri Lanka. He is also a president-elect of Pharmaceutical Society of Sri Lanka. Welcome, Kelum, and thank you for joining. Thank you for accepting our request and being here. And I request you to share your experiences in the area of AMR. So floor is yours.
Thank you, Ms. Manjari, and nice to see you after last FIP. Yes, so I think from Sri Lankan point of view, hope you all can hear me. Okay, for Sri Lanka, actually, we have a kind of a different story, but we are slowly coming to the level as our the neighbor loving India, because I'm delighted to see that India is doing great on this antimicrobial stewardship. Just to start with, because Sri Lanka lack of graduate pharmacists, and or rather we don't have a practicing clinical pharmacist. Even myself is a graduate from India, but I'm into management, though. Now actually recently we got down one PharmD student who has also studied in India. Now she has joined just this month with us. So what we have done actually from the Pharmacy Society of Sri Lanka as well, we spread the awareness anyway. We have done the foundation, of course, like, considering this SBA, now we are putting up the situation in such a way, because not even at the government level, we have a stewardship kind of activity. So Asiri actually being a private hospital, I'm proud to say, we have started in a very preliminary stage for our Asiri, our flagship hospital that's in Colombo, Asiri Central Hospital. So we were doing it with about 4 graduate pharmacists, though they are not fully fledged clinical pharmacists. I was able to train them in such a way, and we start monitoring. We have done audits as well, and slowly we got most of the consultants got convinced, and we have restricted certain antibiotics as well, in even being in a private hospital. But I would say about maybe 30% of the consultants, because we are yet to convince the others. So that's how we start. But with the COVID, of course, even these graduates have left us because fearing COVID. So we really get into trouble without the pharmacists. But now again, we were able to get these pharmacists on board. So what we are doing actually right now is spreading the awareness. I'm yet to go to the community sector, but at hospital. So with some initiatives, what we have done, we start with leaflets, and even today actually we have done a session at Kandy. I'm at Kandy right now, one of the beautiful places in Sri Lanka. So now even Kandy today, we united certain people from the other hospitals, or like General Hospital, our National Hospital. So even now they are also like they promise, or like they pledge. You can see my badge here. Today we have given a badge to everyone, even for the nurses and the doctors. So I'm so delighted because now in today's forum, we had doctors, nurses, infection control nurses. So this is what actually we have started doing now. It's we are still at the situation level, and we are putting up the background as well. So we start doing training, and slowly my plan is, or our plan is to get this communication happen throughout slowly into the community sector as well. Though at my RCB Central Hospital, of course, we do monitoring the drug interactions, and also sometimes we talk to the doctors how to shift into the oral, like from the IV, because I'm sorry, I'm sad to say, because we have a very like high irrational use of antibiotics, because there are still mainly in the community sector, people do dispense on OTC, the antibiotics. So that's very we are in really danger kind of era, as well as we lack statistics for Sri Lanka to prove. Even today's my presentation for the forum in the morning, I had to go for other countries statistics and tell the people like how it happened. So from me, actually, Mrs. Manjari, it's basically we just started this, but I'm sure by next year, I can pledge here at this moment, by next year, I should be able to show you at least the private sector hospitals will be on board with the stewardship program. That's what I have to say. I think next slide, if you can go, the next slide.
Yeah. You just have a few examples to show, I think few pictures to show.
Exactly,
can we go
exactly.
to the next slide?
Next slide, please.
Yeah.
Yes, now this is the first one. Actually, we did a webinar. So we got 313 participants registered, but we had only 200 on the live session. So this was, we got a speaker from UK, Mrs. France, and she has done a wonderful presentation, and she promised that they will help us to implement stewardship in Sri Lanka. And we have done a poster competition. You can see right there in the left down. And this poster competition we have open even for the public. So I'm delighted. We have got more than 400 posters to our for the link. So school children and even university students. So we have given different categories, not only within strict into the only for the pharmacists. So intention is to make this awareness even among the community people, because that has to be done. And of course, this badge you can see now. This we have given away about 1,000 badges yesterday at Matara Hospital. One of the microbiologists, she was very impressed, and she took about 100 badges, and she said she is going to give it to the doctors, and they're also joining hand with us. So I'm sure. And the next two is like, one is in our language, mother tongue, the Sinhala, another one is English. You can see now we are giving this to even temples, all the religious places also. This is only to spread the awareness. Thank you. I think for any country, if you're not started yet, I think this is the best way to touch people's heart. And with a very, because we use very simple language where everybody can understand about stewardships. Thank you.
Thank you, Kel. That was excellent. And your initiative for consumer sensitization or consumer education is really needed. And overall, in our part of the region of the world, irrational prescribing is very common. So what you say in your country, it is, I think, similar situation even we have, even though we are trying to improve it, we have it in India as well as in many other countries. I have heard about the efforts taken in Thailand in this direction, and it's very impressive. So this is the way we learn from each other and we take our work forward. So thank you for your excellent presentation. I really appreciate efforts in Sri Lanka to fight AMR. Can we go to the next slide now? So we had all the three panelists speaking about their own experiences, their own initiatives and efforts. Now we go to the question answer session. And I call all the three panelists here, and they can switch on their videos if you can. All the three panelists here on the screen. Thank you. I can see Karthik, I can see Tilak, and I can see Kelum, as well as my co-moderator, Dr. Virat. Thank you. So I must say all the three presentations, one is focusing on upscaling the pharmacy students for their clinical pharmacy skills. One is trying to improve the community pharmacy practice and trying to do the rational dispensing of antibiotics and improving the responsible use of antibiotics. And Kelum's efforts have been targeted towards community as well as towards the pharmacists. So great going. And now I have a question. For one of the question in the Q&A box was, if we use antibiotic history card for the discharge patients or the patients who visit to the hospital, or I can just add to it that the patients who are visiting to the community pharmacy, will it be useful to reduce the resistance eventually? Because then it would be a specific card which is recording the use of antibiotics for that particular patient. So antibiotic history card, will it be a good idea? In some of the countries it is already done. Will it be a good idea to implement in our own region? So who wants to go first? Tilak or Karthik? Yes, Tilak, go ahead.
Yeah, it will be good, ma'am. But thing is, we have to see what kind of antibiotic was used for which condition. And it's good because if there was a, report along with saying that this person was resistant to this specific antibiotic, so that's helpful for the other physician to actually change the antibiotic what is required for that specific infection. Thank you.
Karthik, do you want to add that? So
Yeah.
What Tilak is saying is that the card should give us much more information than just the name of the antibiotic. So the condition for which it was used and maybe the regimen, right?
Yes, and even the allergy status. So is the patient allergic to,
status,
so the doctor does not make a mistake of choosing that antibiotic or any other antibiotic from same class. Sometimes there is a class effect. And we tried doing this at one of the hospitals. A question from Gokul. So he was the intern there, and I wanted to share an experience. The orthopedician who is from AIMS, who was the heading that hospital, he said, if you pharmacy guys have good knowledge in antibiotics, we can sit and listen to you. That is the statement he gave. So that is how willing a lot of doctors are. He said, I can make all my team to sit and listen, and you can explain us about use of antibiotics. He honestly admitted that because he's an orthopedician, he's not directly involved in treating infections, etc. So he did. So as part of that, this will really help Gokul. Yeah.
I can see that, working with others, one of the FIP development goals is, so working with other healthcare professionals, we need to bring that in here, and then we can definitely go ahead with the antibiotic history card or whatever we name it. One more question was on fixed dose combinations. So how much of fixed dose combinations of antibiotics do you see in Sri Lanka, Kelum? And then coming to the panelists from India. And fixed dose combinations of lactobacillus on the first day of the infection. Yeah.
So at the moment, I don't think we have anything like standardized in that way. There's no proper guideline as well, because that's why I said, so we have to start from the scratch, because actually even imipenems are, it's very commonly prescribed even for where other antibiotics are available. So that's really a kind of a problem. That's what I said. So in terms of even the documents or like any standards, guidelines, we lack all these things. So that's where we need help of FIP as well as from the neighbor countries for us to start with this. So I'm sorry, but we have no such kind of information.
Yeah, ma'am. So to add to that, there are no very clear guidelines on whether probiotic can be given with an antibiotic. I think that was the question. So only one condition where it can help was antibiotic associated diarrhea. And there are many studies against using that also. And coming to fixed dose antibiotics as such, I can talk few examples. So in India for TB, most of the times we gave AKT4 which has rifampin 450 and ethambutol 800. But for some patients, according to their body weight, they will be needing 600 rifampin and 1200 ethambutol. So some errors can happen if patient receive a fixed dose instead of individualizing according to their body weights and their needs. And also I have seen when doctor writes a combination of rifampin plus isoniazid, and when I go and check the patient, the drug which is administered, patient just takes either only isoniazid or only rifampin. To some extent, it is because of the confusing brand names, Arsin or Arsin A, something like that. So these are two of my observations.
Thanks. One question to Tilak. I have one more question to you, specifically for the community pharmacy. People come asking for the antibiotics as a part of like self-medication. And if you don't dispense it, it is very much possible that the patient goes to another pharmacy and gets it. So in this situation, many pharmacists have dilemma whether to dispense or not to dispense, what to do, like whether choose the business or choose our ethics and also abide by the law. So do you face any dilemma in such situation, and what is your experience?
Okay. So with my experience, yes, what you said is absolutely correct. There are a lot of customers who ask for it. Especially they just come up with a common cold and even like they say, I've got a phlegm. Can you give me straight away the azithromycin for next 3 days? I said, no, please. It's not just about me selling the medication. It's not just about getting money off you. It's about my societal responsibility that you should not use antibiotics for such a small issues. And I understand that you can get it from another pharmacy where they can sell it if there's a non-pharmacist available by chance. But I do say that I have to let you know that this is not really necessary to consume, because it's more than money. It's causing harm to your body, your heart. Because there may be changes in the ECG changes with azithromycin and cardiac effects on it, and if you're using for unnecessary reasons. So I would suggest to go for non-antibiotic treatment, just more of a cold medicines or inhalation, steam inhalation and that sort of thing. But if you're really persistent, unfortunately, it's not good on my part to give it to you. But you're free to go and take it. But these are the reasons I would say it's probably not best for you.
Got it. Great. Because this is a very common situation that we face here in most of the part of India, as well as in many other countries. So there is one question here. I can see students of pharmacy who are working or interning in government hospitals or other private hospitals write the antibiotic in use and ask the patients to show the same to every doctor. He'll be listening later in the life. If you can read this question and answer by texting the audience, that will be nice. I just want to have one more question. So I request the panelists, when you get time, you can write the answer to this question here, which is in the Q&A box. One more question here, Kelum, as well as to Karthik, as well as to Tilak. What change in education system or curriculum do you want to see to prepare our pharmacists for their future role as AMR advocates or for AMS? So you have undergone your undergraduate education, and so what changes do you want to see, or what is the pressing need?
Yeah, can I go ahead? Yeah.
Yes, please.
We decided to go on with because there are a few university lecturers as well in this of the practicing of all the training program. So we thought of having a kind of a role model, role play kind of activity where farmers will involve, and when they can see like some actual scenarios there, because I think just like Tilak mentioned, because even in Sri Lanka, most of the time this happens, like, people come and ask that because of the sore throat, they ask azithromycin, directly with the name of the drug. So those scenarios we are trying to implement like role plays, and that's what we thought, rather teaching them too much of theory. We actually trying to even share the tacit knowledge of the people we have. So that's how we are trying to make a difference on, because with some kind of a role play activities to get this in place.
Okay, just a quick answer if you wish to answer, Karthik or Philip. We just have a few seconds. Yeah.
Yeah, like as all of you know, incorporating more of practical aspects, taking case studies and giving them hands-on experience when they follow a doctor, especially in places like Hyderabad, we have infectious disease consultants who are trained in US. Unfortunately, in India, we don't have that program. So once students follow them, go on rounds with them and understand it practically, they will be able to do. And other thing is not limiting them to read a standard textbook. So I always tell students, HIV chapter in a textbook is 20 pages. But when you download the guideline and read, it is close to 1,000 pages. So making them understand the importance of reading standard guidelines. So these are two of my points.
So practice-oriented education is much needed. Tilak, do you want to quickly add anything?
Yeah, I agree with Karthik as well. Like, so what I would suggest in my practice, if I'm like, you know, with pharmacists coming down as trainees, so I would ask them to go through the latest guidelines, whatever is updated in the world, like which condition, which antibiotics needs to be used, how long the duration is, and what's the dose. And depending on the renal condition or liver condition, depending where the drug is getting excreted. So they have to go through that protocol, and based on that evidence, they need to either talk to the physician or the customer and explain them about that.
Yes, I agree. Thank you very much. Sabiha, before we go to the poll, there was one question, and for the benefit of everyone, if you could answer that. Does GRIP have internships for the pharmacy students? Sabiha, if you can go before we go to the voting. And till Sabiha comes back to us, I would just explain regarding the voting. Now, I request all the audience, we will run the polls, and please, there will be 3 questions, and you will be choosing one of the best case study. I mean, what you feel as the best. So there will be 3 questions. Which initiatives are you most likely to implement in your country? Which initiative could be implemented the quickest in your country? And which initiatives do you think would have the biggest impact in your country? And so we had 3 case studies from from India, clinical pharmacist in AMS. Second one was role of pharmacist in antimicrobial stewardship through the community pharmacy. And the third one, role of pharmacist in combating AMR in Sri Lanka and challenges to implement the AMS. So we had these 3 case studies which you listened to, and now we will go for the polls. So we can go for the first poll. You can see the first question, and I request all of you to answer this. Which initiative are you most likely to implement in your country? So please choose one of the case study and submit your answer. Thank you.
Wow. As you see in the picture, case number 1 is the most 54% most likely to implement in your country, followed with the case number 2, 29%, and case number 3, 16%. Okay. Let's reward for the second question. Which initiative could be? Yes. Let you, Manjiri, quick add.
Can we go to the second poll now? Yes, here it is.
For the second question, which initiative could be implemented the quickest or the most quickly in your countries? Choose 1 or 2 or 3. Quick add. almost quickly. Clinical pharmacist in AMR, or the second law of pharmacist in antimicrobial stewardship in community pharmacy or retail pharmacy. And the third one is a law of pharmacist in combat AMR in Sri Lanka and challenge to implement AMS. For the second one, the most popular is a case number 2, 48%, follow with the case number 1, 40%, and case number 3, 11%. Okay. Yes, we will go to the third questions. Which initiative do you think would have the biggest impact in your countries? Case study number 1, or number 2, or number 3? Let Wow. The result is case number 1, 42%, case number 2, 38%, and case number 3, 21%. Let Manjali, let you
Yes,
conclude
Virat. Do you want to announce the winner?
No,
So
let you. Yes.
So the winning case, all 3 case studies were really interesting and inspiring too. And everybody has their own set of efforts. So the first case study, which we had from India regarding the education of the clinical pharmacist and improving the clinical pharmacy services, will go to the global event. Can we go to the next slide, please? So the global event is scheduled on 30th of November. Can we go to the next slide? Yes. So the first case study, which was presented today by Dr. Karthik Rakam, will it's selected for the global event, which is scheduled on 30th of November. And congratulations, Dr. Karthik Rakam. And so on this 30th of November, the global symposium. So all these regional events are culminating into the global symposium, which is scheduled, as I said, on 30th of November, 11 a.m. Central European Time. And so the idea which is most impactful, that is the case study 1 for today, is chosen for the global symposium. And please don't miss this global symposium. I request and appeal all of you to register for this event. And in this event, we will have a very exciting and lively discussion, rather a debate on our pharmacist protagonist in the fight against antibiotic resistance. So there will be 2 groups, one opposing, one supporting, and we will have a very lively discussion on that day. So please do register for this event as well as for the other digital events. FIP Commission on Antimicrobial Resistance, which was set up in last year in September 2020, will monitor the progress on AMS roadmaps annually, stimulating the global community of pharmacists to be an active agents in minimizing AMR. So this is the 1 year we have completed of the AMR Commission, and we have seen how much progress we have made in this roadmap, and every region has made the progress, and we would continue to do this progress and come back next year to monitor it and present it to all of you. For this AMR events, I acknowledge the support of GRIP, Global Respiratory Infection Partnership, as well as the support from the Reckitt. Thank you very much. And these are the events which are hosted by FIP, Antimicrobial Resistance Commission, and supported by Reckitt and GRIP. I also thank my co-moderator, Virat. Do you want to add something, Virat, here? Thank you very much for your support. Would you like to have some? Yes.
Thank you for support everything. And today is an exciting case study to present to next week. I think we will register together to see the showcase next week. Thank you.
I'm looking forward to the, yes, Virat, thank you. I'm looking forward to the Global Symposium on 30th, and I'm sure all of you will be attending with much larger group of attendees from world over. Can we go to the next slide? And thank you to all the 3 panelists for joining us here and for sharing your experiences. It was really an inspiring session because we can see your work in the field and how you're trying to transform the pharmacy practice or the consumer behavior. I believe that bringing the change in the behavior, whether it is consumers or the pharmacist or the policymakers, it is really difficult, but you're trying for it and you have some success, and that is really encouraging for all of us. So let's continue our efforts. Let's join our efforts in the fight against AMR. And thank you very much to everyone again. You have a good day, good evening, and good night, and see you all on 30th of November for the Global Symposium on Antimicrobial Resistance. Thank you all.
Thank you all.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye. Thanks.
Bye.